All right, let's get right into this explainer on the algorithmic framework for Step 2 CK Pulmonary Oncology. We're focusing purely on the next best step decision logic.
Here's the roadmap for this explainer. We've got lung cancer screening, the solitary pulmonary nodule algorithm, tumor histology and paraneoplastic syndromes, surgical fitness for resection, pancoast and carcinoid tumors, and finally malignant pleural effusions. Let's go.
Section 1. Lung cancer screening. So who actually gets screened? You need a yearly low-dose CT for adults specifically between 50 and 80 years old. But age isn't the whole story. They absolutely must have at least a 20-pack-year smoking history to qualify.
Now, it's crucial to know exactly when to start and when to stop. You start screening if the patient currently smokes or if they quit within the past 15 years. But you stop screening once they've been smoke-free for 15 years or more. You also stop if they develop a medical condition that substantially limits their life expectancy or their ability to actually undergo curative treatment. For the exam, you've got to recognize when that mortality benefit just isn't clinically relevant anymore.
Section 2. The solitary pulmonary nodule algorithm.
When you find a solitary pulmonary nodule, your absolute first step every single time is to compare it with prior imaging. If a solid lesion was on a previous scan and hasn't changed size for over 2 years, malignancy is effectively ruled out. You stop there, no further testing needed. But if you don't have prior imaging, or if it looks like it might have grown, your next best step is getting a chest CT to stratify the risk.
Okay, you've got the CT. Now you're looking for specific visual clues. On the benign side, look for calcification patterns, like popcorn, which is classic for pulmonary hamartomas, or concentric, laminated, central, and diffuse patterns. On the flip side, what are the high-risk malignant features? You're looking for eccentric, punctate, or reticular calcifications. Spiculated margins with a corona radiata are huge red flags. Other risk factors include a nodule larger than 2 centimeters, older patient age, and current smoking. All of those demand immediate attention.
So, based on that chest CT, what happens next? Low-risk nodules just need serial CT tracking and sometimes no follow-up at all depending on their exact size. Indeterminate or suspicious nodules? Those proceed directly to further investigation with a PET scan or biopsy. And if that nodule is highly suspicious for malignancy, the patient goes straight to surgical excision, assuming they're a surgical candidate, of course.
Moving on to Section 3. Tumor histology and paraneoplastic syndromes.
This is a great mental map to separate central cancers from peripheral ones. Adenocarcinoma is the most common, making up 40 to 50% of cases. It's usually peripheral, it's the most common type in non-smokers, and you'll often see it associated with clubbing or hypertrophic osteoarthropathy. Squamous cell carcinoma, on the other hand, is central and prone to necrosis. Small cell carcinoma is also central, very strongly linked to smoking, and is notorious for paraneoplastic syndromes. Finally, large cell carcinoma is usually peripheral and can actually cause gynecomastia or galactorrhea.
Take a look at this. Squamous cell carcinoma frequently presents with classic central cavitation and necrosis, complete with an air fluid level, just like this. And keep in mind, squamous cell is distinctly linked to PTHrP-mediated hypercalcemia. So if your patient has hypercalcemia with suppressed PTH, you need to evaluate for PTHrP and think about this specific malignancy, as well as vitamin D and granulomatous disease depending on the clinical story.
Now, small cell carcinoma has its own set of highly testable paraneoplastic traps. SIADH is a big one. That causes euvolemic hypotonic hyponatremia with inappropriately concentrated urine and high urine sodium. Ectopic ACTH can trigger Cushing syndrome. Then there's Lambert-Eaton syndrome, which causes proximal weakness, autonomic dysfunction, and decreased reflexes. The tricky part? The strength actually improves briefly with repeated muscle use. If you see these clinical pictures, immediately evaluate for small cell malignancy.
Section 4. Surgical fitness for resection.
Identifying a resectable lung cancer is only half the battle. You have to know if the patient can handle the surgery. Preoperative pulmonary function testing is mandatory here. A lobectomy is the standard surgical approach for many lung cancers, and FEV1 and DLCO are your absolute best predictors for postoperative outcomes. Generally speaking, a patient can safely tolerate a lobectomy if their FEV1 is above 1.5 liters and their DLCO is greater than 60%.
Section 5. Pancoast and carcinoid tumors. This MRI shows a massive pancoast superior sulcus tumor right in the lung apex. Because of its location at the very top of the lung, it invades locally into the surrounding structures. That's why the initial symptom is almost always severe shoulder pain. The mechanism here is direct invasion of those adjacent neural pathways. If it invades the paravertebral sympathetic chain and inferior cervical ganglion, you get Horner syndrome. That's ipsilateral ptosis, meiosis, and anhidrosis. If it hits the C8 to T2 lower brachial plexus, you see highly specific neurological deficits. We're talking weakness or atrophy of the intrinsic hand muscles, plus pain and paresthesias in the 4th and 5th digits and the medial arm and forearm. Supraclavicular lymph node enlargement and weight loss are also classic clues to watch out for.
Now let's talk about bronchial carcinoid tumors. These are neuroendocrine tumors derived from bronchial Kolchitsky cells, which makes them the most common lung cancer in adolescents and young adults. They notoriously cause proximal airway obstruction. The presentation is usually a triad: wheezing, hemoptysis, and recurrent pneumonia that happens right distal to the obstruction. For diagnosis, you're looking at contrast-enhanced chest imaging showing a vascular tumor with an endobronchial component, followed up by bronchoscopy with a biopsy. Carcinoid syndrome is actually less common here than it is with midgut carcinoids, but keep it in mind.
Finally, Section 6, Malignant Pleural Effusions. Whenever you have a new, unexplained effusion, you have to investigate. If the fluid analysis comes back exudative, bloody, or lymphocyte predominant, that strongly suggests cancer, tuberculosis, or a fungal disease. If you have a patient with known or suspected lung malignancy, getting a thoracentesis with fluid cytology is your immediate next best step to lock in that diagnosis.
Once you have the diagnosis, if that malignant effusion is recurrent and symptomatic, like causing progressive dyspnea, you need to think about definitive palliative management. The logical pathway starts with the initial thoracentesis for cytology, moves to repeated drainage if they stay symptomatic, and ultimately leads to pleurodesis to scar the pleural space closed, or placing an indwelling pleural catheter for ongoing symptom control. Knowing this step-by-step logic is exactly what will help you select the right palliative intervention on the exam.